Thank you. Good morning. Sheila, that was a beautiful tee-up to this lecture. By way of hands, how many of you are using ultrasound O-RADs in your practice? I think a few. And anybody using MR O-RADs? Yeah, a few. I think this is going to be used more and more. It's kind of how LIRADs took a while to gain momentum, and I think most of us use LIRADs now. I would suspect we'll be using O-RADs ultrasound and MR more and more. And I am really grateful to Marissa Martin at Michigan, Liz Sadowski at UW Health, and my colleague Nancy Kim at Georgetown for a lot of this case material. So by way of an outline, why O-RADS MRI, why are we doing it, and what is it? What are the technical considerations we need to think about when we're doing an MR of the adnexa? We'll spend a fair amount of time on lexicon because all of the RADs that we have in our imaging armamentarium really work with relation to a lexicon, an approach to how to use the O-RADS lexicon, and talk a little bit about risk stratification, and then go on to cases. So what is O-RADS MRI? Well, it is a risk stratification system that really relies on a standardized lexicon to arrive at an evidence-based risk score. And what are the goals? Well, they're twofold. It is to unify management pathways and support outcomes research. So again, why O-RADS MRI? We just heard about O-RADS ultrasound, which is brilliant, and in Sheila's hands is incredibly specific. But we do know that there's a proportion of masses on ultrasound that remain indeterminate, even in the best of hands. And this was a study done by Isabel Thomas and Nagara. Andrea Rockwell was the senior author, and it was a prospective multi-center cohort study that looked at O-RADS MRI score for risk stratification of sonographically indeterminate adnexal masses. And they evaluated over 1,500 pelvic masses in a little over 1,100 women. And what they found was that the O-RADS MRI score had a sensitivity of 93% and a specificity of 91% with an accuracy of 92%. So that's very positive and encouraging. And when you compare O-RADS MRI and O-RADS ultrasound, you see that MR has a higher specificity and a higher positive predictive value for malignancy. And you can see by looking at O-RADS 1, 2, 3, 4, and 5, if you compare the ultrasound numbers versus the MR numbers, positive predictive value, recognizing they have the same shared terminology, you can see that MRI has that higher positive predictive value, most pronounced for O-RADS 4, which is about 50%, as opposed to ultrasound, which is 10 to less than 50%. And for O-RADS 5, ultrasound has greater than or equal to 50%, whereas MRI has a 90% positive predictive value for malignancy. What does that all mean? Well, it really means we can decrease the number of indeterminate lesions and reduce the number of inappropriate procedures, and that goes both ways. First of all, you want to do the right surgery the first time for a patient who has ovarian cancer. So you don't want to have a woman who has ovarian cancer and has the wrong surgery the first time. Her best chance of cure is that first debulking surgery and staging surgery. Conversely, you want to limit overextensive surgery for benign or borderline lesions. So it sort of cuts both ways. By being more specific, we can tailor the right therapy for that patient. Also, MR's large field of view allows us to better identify the origin and extent of some diseases, because not every adnexal lesion is ovarian in origin. So that large field of view gives you some more information. What are the technical considerations? And this is from the ACR website. I would counsel you, if you don't have a usual protocol that you use or you want to get more familiar with it, this is on the ACR website. Basically, we do orthogonal T2-weighted fast spin echo with high resolution, again in orthogonal planes. We do an axial T1-weighted sequence with or without fat suppression, or a four-image Dixon vibe. We always get diffusion-weighted imaging with a high B value of at least 1,000. And if possible, dynamic contrast-enhanced post-contrast imaging is preferred over static post-contrast imaging. The dynamic sequence, and again, it goes into all the specifics in your handout and online, allows you to generate time intensity curves, which are the best way to evaluate these adnexal masses. If you don't have the ability to do a dynamic contrast-enhanced study, then you have to do a pre-contrast axial T1 weighted fat suppressed technique, give contrast and wait about 30 to 40 seconds post-injection to acquire your post-contrast imaging sequence. This is what the O-RADS table looks like if you go on the website, if you look in your handout, and you'll notice that you have, O-RADS MRI score, risk category, positive predictive value of malignancy, but it very much focuses on that last column, that is the lexicon. So it's a standardized lexicon, and just like with LIRADS, you have an observation. You have to decide initially, is your observation physiologic, and if it is, that's an O-RADS 1. And by physiologic, we mean a follicle. It can be a dominant follicle, or we mean a corpus luteum. If it's non-physiologic, then we get into sort of the lesion or the notion of a lesion. And a lesion may be cystic, it may be cystic with a solid component, or it may be solid. And what I mean by solid is it has to have at least 80% of the lesion has to be enhancing solid tissue. These are very nice pictures and schematics from University of Michigan, sort of illustrating this standardized lexicon, but a picture's worth 1,000 words. So for a unilocular cyst, we have a single locule on this T2 weighted sequence, multilocular cyst, many locules separated by septations, a unilocular cyst with solid components. So again, it's not just a simple cyst, but there's enhancing soft tissue. Similarly, a multilocular cyst can have solid elements with enhancing tissue, and then the solid lesion, again, at least 80% of that lesion is solid enhancing tissue. The lexicon further specifies the type of fluid, and there's T1 fat suppressed technique on the bottom and a T2 on the top row. And fluid can be simple, that is low on T1, bright on T2. It can be hemorrhagic, bright on both T1 and T2 weighted sequences, right, methemoglobin. It can be endometriotic, and the most typical appearance of an endometrioma on MRI, or the most specific, is high signal intensity on T1 fat suppressed technique, falling in signal, or called shading, with a loss and dropout in signal on T2 weighting. And then there's proteinaceous, which very much parallels the hemorrhagic findings, which is not surprising, they're both protein, high on both T1 and T2 weighted sequences. But it gets more complicated, or it gets more specific. It's not good enough just to talk about cysts versus solid and locules, or to talk about the fluid components per se, but you have to discuss the solid enhancing tissue if you see any. So you can have a nodule, as you can see on the image on the left. It's a cystic lesion that has some soft tissue enhancement. You can have irregular septations that enhance. They're not thin and wispy. They're kind of nodular and irregular. You can have papillary projections, and Dr. Sheff just talked about that. That's often seen in borderline serous tumors, and they have a fibrous core and this enhancing sort of cauliflower-like look, and that's the neoepithelium that enhances. Or you can have a straight solid up mass where 80%, like I said, is enhancing solid tissue. And then it gets to non-enhancing solid tissue, which initially when I read that, I'm like, I don't even know what that means. But it makes sense. Hemorrhage or debris, it's solid. A clot is solid, but it's not going to enhance, as we can see in this case here. The fat in a simple dermoid is also solid tissue, but we don't see enhancement. So that would also qualify as solid tissue that doesn't enhance. And finally, smooth septations, while we could argue they enhance, if they're thin and smooth and gracile, we consider that sort of non-enhancing tissue. And then it comes down to these time intensity curves, which again, if you have the ability to do dynamic contrast enhancement and you can acquire a series of images over 4 minutes, you can generate with just the push of a button on your scanner or your PAC station these time intensity curves. And there's 3 types. There is the low risk curve, and what you're doing is putting a region of interest on the adnexal mass and comparing its enhancement pattern compared to normal myometrium. So you have to have a region of interest on the solid enhancing adnexal mass and then a region of interest on the myometrium. And if it's a low risk time intensity curve, there's just a barely minimal increase of contrast over time. That's low risk. If, however, there's a little bit more of a steeper curve and then it kind of plateaus off, but the slope of the curve is less than the myometrium, that's considered an intermediate risk curve. Whereas if you have a region of interest on the adnexal mass and a region of interest on the myometrium, if that adnexal mass enhances better or higher than, not better, I guess, stronger or steeper than the myometrium, goes up and then kind of plateaus off, that's considered a high-risk curve. So you can really stratify low risk, intermediate risk, and high risk, the most important being high risk, where the slope of the enhancement of the adnexal mass is steeper than that of the myometrium. And the governing principles of O-RADS, whether it's ultrasound O-RADS or MR O-RADS, is that it's guidance rather than requirements, which I say is a CYA kind of statement. It's used or applied to low-risk patients. We often don't know the reproductive status on MR. You know it much more often on ultrasound, so we make assumptions. If the patient is less than 50, she's premenopausal. If she's 50 or over, she's postmenopausal. And if the patient has multiple and or bilateral lesions, you characterize them separately with guidance driven by the lesion with the highest score. And certainly, like I hope I've emphasized, dynamic contrast enhancement with time intensity curves is preferred over static contrast enhanced imaging. If a patient has peritoneal disease, we know that's going to be a metastatic disease and it's going to be a malignant process. That's an O-RADS 5. If she has a normal ovary or follicle or corpus luteum or hemorrhagic cyst that's less than or equal to 3 centimeters and she's premenopausal, she's O-RADS 1, almost certainly benign. If we see a lesion that has a lipid component without any large amount of enhancing tissue, it's an O-RADS 2, again, almost certainly benign. And if she has a large volume of enhancing tissue, then we're kind of worried, and that's an O-RADS 4 with a positive predictive value of 50% for malignancy. For solid tissue, there's something that we call the dark lesion. Dark on T2, dark on diffusion-weighted imaging, and that's an O-RADS 2 lesion. And those refer to the fibromas, fibrothecomas, Brenner tumors, and cyst adenofibromas. All other lesions that have solid tissue, we have to really look at their time intensity curve if you've generated one, or post-contrast imaging at 30 to 40 seconds after contrast. And when talking about locularity, if something's multilocular, you don't have to sit there scratching your head, oh my golly, Susan, there's different signal intensities. That's an O-RADS 3. If it's unilocular, no wall enhancement, that's an O-RADS 2, almost certainly benign. If there's wall enhancement, then that's going to help you determine the score. Whether it's fluid, the type of fluid, is it simple or endometriotic, O-RADS 2, less than 0.5% chance of being malignant, or if it's hemorrhagic or proteinaceous, depending on the patient's hormonal status, it's either going to be an O-RADS 2 or an O-RADS 3. And that was a lot of words, but it gets really great because this is your O-RADS MRI calculator. So those last 5 slides you don't have to memorize. This is really game-changing. This was a calculator developed by Liz Sadowski and Caroline Reinhold, and their brilliant sons did all the coding. And this is online. So that series of questions that I just went through, it asks you that, and then at the end, it spits out a score. So how great is that? Which means that you really have to understand the lexicon and what the different lexicon means and how to pick that up on imaging. So this is really, the risk stratification. Again, O-RADS 1, normal or physiologic. O-RADS 2, almost certainly benign, less than 0.5% chance of malignancy. O-RADS 3, low risk, about 5% chance of malignancy. O-RADS 4, an indeterminate risk, about 50%. And O-RADS 5, high risk of malignancy, 90%. So let's look at some cases of the different O-RADS scores. Normal ovary, right? Normal premenopausal ovary, you'll often see small follicles distributed within the ovarian parenchyma. You can have a dominant follicle, especially in premenopausal women, that tend to be less than or equal to 3 centimeters. You can have a hemorrhagic cyst. We said that's going to be bright on T1, bright on T2 with no enhancement or no mural nodules or papillary projections following contrast. Or you can have a corpus luteum, again, that very enhancing, thick, crenulated border around a cyst. And those are all in the premenopausal ovary. For a postmenopausal ovary, often they're hard to see. They're just sort of little almond-shaped lesions, or I shouldn't say lesions, structures in the adnexa, recognizing, as Sheila said, that often the more we look at this and the better our imaging gets, many times women have small, simple cysts. And a postmenopausal woman with a small, simple cyst, that is not cancer. That's within the normal appearance. O-RADS 2 is almost certainly benign, positive predictive value less than 0.5% for an ovarian mass. This includes unilocular cysts, any fluid type that's greater than 3 centimeters, no wall enhancement, no solid tissue, no mural nodule, no papillary projection, no thickened internal septae. Similarly, you can have a unilocular simple cyst greater than 3 centimeters that has smooth wall enhancement, but no solid tissue. So smooth wall enhancement is not worrisome. Irregular wall enhancement, papillary projections, mural nodules, that's far more worrisome. O-RADS 2, again, almost certainly benign, a 0.5% positive predictive value for malignancy. A dermoid, right? We said that was solid, non-enhancing tissue. These are bright on T1 weighted sequences without fat suppression. You do your next sequence with fat suppression, that high signal intensity drops out because of the macroscopic fat. On T2, that fat will often follow the signal intensity of the pelvic fat. An endometrioma is also in this category. Remember, bright on T1 weighted fat suppressed technique, often multiple in most cases, which falls in signal that is shading on T2 weighted sequences. Again, O-RADS 2, almost certainly benign. And then you get to this lesion. There's a lesion that's pointed to on this patient's right. It's low on T2, low on diffusion weighted imaging with a high B value. It's that T2 dark DWI solid lesion sign. That's a lot to say. I just say dark T2, dark DWI. And that's often seen with fibromas, fibrothecomas, some other lesions as well. And again, less than 0.5% chance of malignancy. And this in category also would include a simple hydrosalpinx. So you'll see a tubular structure, low on T1, bright on T2. You give contrast. The folds can enhance, but they're thin. They're not thickened. There's no papillary projections or anything more complex about it. So a simple hydrosalpinx is also in the O-RADS 2 category. Moving on to low risk of malignancy, this is the O-RADS 3 category. It has a positive predictive value of malignancy of about 5%. And this would include a unilocular cyst, be it proteinaceous, hemorrhagic, or mucinous, with a small enhancing wall. So this wall is not as thin as others, but you don't see any real papillary projections or mural nodules. You can have a multilocular cyst with no solid tissue. I think we all get a little anxious when you see a multilocular cyst, what am I dealing with? But really, you have to look at the post-contrast imaging. And if the locules have different signal intensity, and you give contrast and you can't tell if it's enhancing or not, that's where subtraction post-processing is very robust. This is also the O-RADS 3. This is low risk of malignancy. And here we have a dilated fallopian tube. It has non-simple fluid with thin walls and folds and no enhancing solid elements. So to your left is a serpiginous tubular structure. It's got heterogeneous signal intensity, certainly higher than simple fluid on a T1 weighted fat suppressed technique. So you were thinking protein or blood. On T2, we're also seeing heterogeneous signal intensity. And then that third image to the right is post-contrast. And I think it's very hard on that just straight post-contrast image to say whether or not there's something nasty that's enhancing underneath. And again, that's where your post-processing with subtraction is really robust. Hopefully there's no misregistration and the patients don't move much in the pelvis between breath holds. So you really often can get a very good subtracted image. And this shows you that there's no papillary projections, mural nodules, or any complicating enhancing solid tissue elements. Again, in the low risk of malignancy category, this is a lesion that has solid tissue, so we have to analyze that time intensity curve, and this is a low risk time intensity curve. Again, putting your region of interest on the largest portion of this solid part of that adnexal mass, put a region of interest on the myometrium. You compare those two curves, and you can see here just very gradual enhancement over time, and that's a low risk curve, about 5% chance of malignancy. This is an intermediate risk, O-RADS 4, intermediate risk for malignancy, about 50%. And this is a lesion with solid tissue that has a time intensity curve that goes up more so and with a higher upstroke than the low risk, but less than the adjacent myometrium. And this is a intermediate curve, again, risk of malignancy about 50%, Remember, your region of interest has to be on the enhancing tissue of the lesion, and you compare that to the myometrium. So there's our lesion, there's the high signal intensity on diffusion-weighted sequences, and you can see the regions of interest in green and purple to your right. This is an O-RADS 5, highest category. This has a high risk of malignancy, a positive predictive value of about 90%. And this curve, when you compare them, you can see that the adnexal mass has a steeper slope than the myometrium. And this is worrisome, and this would put you into the O-RADS 5 category of high risk for malignancy. Again, you want the region of interest on the largest part of the solid enhancing part of the adnexal mass and compare it to a normal myometrium. Obviously, you don't put your region of interest on fibroid or an adenomyosis. You have to find normal myometrium in the adjacent uterus. Hopefully they have their uterus. This is another case of O-RADS 5, high risk of malignancy. And in this, you notice there's no curve because this patient has peritoneal disease. And again, if you see ascites, a complex adnexal mass, areas of restricted diffusion, you know that this is going to be malignant. You don't have to put a curve on this at all. So this was an O-RADS 5. But what if you say, and you raise your hand, you're going, well, that's really great, Susan, but either we don't have that capability to do those time intensity curves, or that takes time and we're uncomfortable in our outpatient office, we're just not going to do it. No worries. While not maybe as good, you can certainly get away with pre and post contrast imaging, and I think that's pretty de rigueur for most of us. And what's important is you compare your adnexal lesion to the myometrium at 30 to 40 seconds post contrast. Give your contrast, wait 30 to 40 seconds, make your acquisition, and then you compare the enhancement of that lesion to the myometrium. If it's less than or equal to the myometrium, that's an O-RADS 4. We said, like a 50% chance of malignancy? And if it enhances more than the myometrium, that's an O-RADS 5, 90% chance of malignancy. So here's some examples. It's a 36-year-old woman. You can see her T1, T2, T1 FATSAT, and T1 post-contrast imaging. And you can see that anterior aspect, which had high signal on T1 without fat suppression, falls with fat suppression, no solid tissue enhancing, no enhancement. This is an O-RADS MRI 2, almost certainly benign. It's a dermoid cyst. Next is a 45-year-old female. You can see sort of multilocules on T2 and T1 of different signal intensities, but post-contrast imaging, there is no enhancing solid tissue, no papillary projections, nothing untoward. This is a multilocular cyst. It really doesn't matter what the different locules, their signal intensity. It has no solid enhancing tissue. This is a low-risk lesion, O-RADS 3, and this is a serous cyst adenoma. Next is a large lesion. You can see sort of this donut looking at you on the T1 weighted sequence. If I showed you the fat suppressed image, that donut would fall in signal. On the post-contrast imaging, you don't really see much when you first look at it, but look up to the right. This is a fat-containing lesion with a large amount of solid tissue, and this would place the patient into the O-RADS 4 intermediate category for malignancy with a positive predictive value of about 50%. And we can argue with what constitutes a large amount of solid tissue, but I think, when you see this much, it's not like a little bit. It's not a Rokitansky nodule in the normal sense. I think you have to be concerned. This also, though, turned out to be a dermoid. This is a 48-year-old female, again, a multilocular lesion. That shouldn't freak you out. It's okay to have locules of different signal intensities, but you have to look at the post-contrast imaging where it is complicated by these thick, irregular nodular septations, and that is more worrisome. So multilocular cyst, solid tissue, enhancing less than the corresponding myometrium. Remember, at the 30 to 40 seconds after contrast is when you do the comparison, and this is an O-RADS 4 intermediate risk lesion, and this turned out to be a borderline mucinous cyst adenocarcinoma. Here with a 55-year-old female, you see the T2, T1 post-contrast imaging, and again, they show you that. I'm showing you that last image, showing you that we're comparing it to the myometrium at 30 to 40 seconds post-contrast, and we have a cystic lesion with solid tissue enhancing more than the myometrium. That's O-RADS 5, that's a high-risk lesion. So 30 to 40 seconds post-contrast, compare the enhancing solid portion of the lesion next to the myometrium, and that's how you make your determination, usually between O-RADS 4 and 5. And this turned out to be a serous cystadenocarcinoma. So what are the complementary roles of ultrasound O-RADS and MR O-RADS? Well, MRI may downgrade a lesion. If a lesion is seen on ultrasound and it turns out on MRI to be dark on T2 and dark on diffusion-weighted imaging, you can downgrade it. And also, if that is present without any enhancement, you can also downgrade a lesion on MR. Similarly, MRI may upgrade lesions. Small elements may not be visualized within a cyst. You may have a really large cyst where you don't see the papillary projection well in an ultrasound, whereas an MRI would find it. Also, you can have a score change just due to differences in vascularity assessment, especially if you do time intensity curves. And like I said earlier in the talk, MRI may reveal an unexpected origin for a mass. Not everything in the adnexa is ovarian in origin. So just finishing up with some examples, here was a case where there was a downgrade from O-RADS ultrasound 4 to an O-RADS MR of 2. This was a postmenopausal woman with an incidental adnexal lesion at ultrasound. I don't read ultrasound, but those that are much smarter than us saw this lesion, or than I rather, saw this lesion. On MR, it was bright on T1 weighted sequences. It fell in signal on T1 weighted fat suppressed technique. No enhancement post-contrast. O-RADS MRI 2, this turned out to be a dermoid. Another downgrade from an O-RADS ultrasound 4 to an O-RADS MR of 2. This is a postmenopausal woman with an incidental adnexal lesion at ultrasound. And you can see that these green arrows are pointing to this area within the mass that has low signal intensity on T2, low on high B-value diffusion-weighted imaging, and is solid post-contrast. So this is a solid T2 dark, and this turns out also to be O-RADS MRI 2, a serous cyst adenofibroma. So that T2 dark, DWI dark can really help you when you're having an incidental indeterminate adnexal lesion on ultrasound. Another downgrade of O-RADS ultrasound 5 to O-RADS MR3 is a postmenopausal woman with a solid mass. You can see the mass on ultrasound, kind of heterogeneous on T2. If you look at it, it enhances post-contrast, and you look at the curve, and you can see this, at least the slope of the curve is not greater than the adjacent or the corresponding myometrium. And this is a solid mass with a it's hypoenhancing compared to myometrium. It has a low-risk time intensity curve, and this is an O-RADS MRI 3, and turned out to be a fibrothecoma. Now, you can also upgrade. This was one that was an ultrasound 3 on O-RADS, and then went on to O-RADS MR4. It was a premenopausal woman with a solid right adnexal nodule at ultrasound. And on MR, if you look closely, you can see that, yeah, there's high signal in this cystic lesion, but it looks like there's a papillary projection, and this papillary projection was enhancing. This had enhancements similar to the myometrium using pre- and post-contrast imaging, making it an O-RADS MRI 4, 50% chance of malignancy, and this turned out to be a serous borderline tumor. To reinforce what Sheila said, when you see papillary projections, that's most often seen in borderline tumors. So by way of conclusion on O-RADS in general, it's a multimodality characterization. Obviously, we always start with ultrasound, but MR can be very complementary. The goal is really to maximize accuracy and minimize inappropriate treatment with women with adnexal masses. Our standard lexicon really improves our communication, and risk stratification allows for outcome assessment as well as improved diagnostic performance over time. Thank you for your attention.